Well, good morning, Madam Secretary. Sorry to be late. I don't really have any good excuse. I just got involved in some
I don't
things.
think the chairman is ever late, sir.
Well, I think so. I detest being late. Anyway, let me welcome you here today. It's good to have you at an historic time as you and your department begin to develop the health reform legislation or implement the health reform legislation we just passed. That debate has been going on a long time, and the Congress and the President have finally made some decisions. And to me, the job at hand now is to try to implement it, make it work, see whether adjustments need to be made down the line, and make certain that it develops in a way which is beneficial to the American people. In this subcommittee, we've been doing a number of things to make health care more accessible, more affordable, and more effective. In the Recovery Act, for instance, we accelerated those efforts. For example, we've been expanding education and training programs to address the shortage of nurses, primary care doctors, and other health professionals, and to encourage more practitioners to go into primary care and to practice in places where they're most needed. As far as I'm concerned, that means especially rural areas. Our regular appropriation bills have increased funding for health profession programs by 35% over the past 4 years, and the Recovery Act included another $500 million for that purpose. Another focus has been on prevention. We provided $1 billion for prevention and wellness activities to jumpstart new efforts in this area. I should add at this point that one of my special concerns is the area of hospital infections. It just seems to me that that has to be at the top of our list in terms of priorities. We don't do people any favors if we give 30 million people additional access to health care and then they wind up dying because of something that they caught in a hospital. That happens at a disgracefully high level lately, and I think we need to be very aggressive in doing something about it. Our subcommittee has also emphasized medical research. That includes basic and applied research supported by the National Institutes of Health. It includes patient-centered health research to help practitioners decide which treatment works most effectively for their patients and thereby improves outcomes. The Recovery Act added $1.1 billion to support a major expansion of patient-centered research. Yet another priority has been to encourage a more widespread use of information technology and electronic health records to reduce medical errors and to make healthcare delivery more efficient. In the 21st century, piles of paper are not the way we ought to be managing records that are vital to patient care. And as you know, the Recovery Act included $19 billion to launch a major push for adoption of those technologies. Finally, we have the need to combat fraud and abuse in health programs. We increased discretionary funding for this purpose by 57% last year to support a wide range of activities, from reviewing Medicare claims to prevent improper payments to conducting criminal investigations. We held a separate hearing on that issue several weeks ago. While these and other healthcare priorities are at center stage, HHS also has many other responsibilities. Its human service programs help families with access to child care, help low-income people pay their winter heating bills, and assist older Americans through programs like Meals on Wheels, to give just a few examples. The need for these services has grown during the current recession, and we've given the department resources to respond to both the Recovery Act and our regular appropriation bills. The President's budget request provides further increases in some high-priority areas, including biomedical research at NIH, child care, Head Start, mental health and substance abuse programs, and health fraud and abuse control. On the other hand, I am not at all thrilled at the proposed 35% cut to LIHEAP, and I'm also concerned that we're not yet well prepared to deal with public health emergencies like a flu pandemic or bioterrorism. I should also mention again that the administration has put us in a box, not you, but frankly the White House has, by one aspect of their budget submission, because they have left a very large hole to fill with respect to Pell Grants. And if we're going to meet our obligations in that area, we need to have that problem addressed, or a lot of people's priorities, including the administration's, will suffer greatly. So with that, let me welcome you. I look forward to hearing from you, but first let me call on Mr. Tiat for whatever comments he might have.
Thank you, Mr. Chairman. As always, it's good to have Secretary Sebelius, the former governor of Kansas, before the committee today. I have a great many questions for the Secretary, so in the interest of time, and hope we'll get to at least 2 rounds of questions, I'm going to be brief. Like many Americans, I have some very serious concerns about the recently enacted government takeover of health care in this country, what many refer to as Obamacare. I have concerns about what it will do to the quality of care people in this country currently receive, what it will do to small businesses and the people who work for them, and I have concerns about what it will do to our already hemorrhaging Treasury. The level of spending authorized under this new law is breathtaking, not to mention the audacity of the federal government under this new law, telling individual American citizens what they must do in regard to health insurance. Many of us oppose the new law and have serious concerns about what it means both in terms of the cost as well as the role of the government in healthcare decisions. Over the last 2 years, the President has made a number of promises regarding this new healthcare law. On June 15, 2009, the President said, "If you like your doctor, you will be able to keep your doctor, period. If you like your health care plan, you will be able to keep your health care plan, period. No one will take it away, no matter what." Well, with the $130 billion in cuts to the Medicare Advantage plans, it sure seems like 11 million seniors will be in jeopardy of losing their plan. The President also said on March 25th of this year that if you already have insurance, this reform will make it more secure and more affordable. Apparently that's true unless you are one of the millions of Americans who buy an individual policy that you like and want to keep. I'm also concerned about the pressure that the host of newly authorized programs will force on other important programs in this bill. There are at least $100 billion in specific authorizations that Congress will be expected to fund, and countless billions in programs with wide, open-ended authorizations. We have no idea how high those costs will be. I could go on, but the bottom line for me is what was promised isn't what was delivered. I look forward to the opportunity to ask a few questions, and I thank the Chairman and yield back.
Mr. Chairman, I'd prefer to wait, listen to the Secretary, and then ask questions.
Well, thank you, Mr. Chair. On? Thank you. Thank you, Mr. Chairman. It's good to be here in the subcommittee with you, with Congressman Tiahrt, and other members of the subcommittee. I want to thank you first for inviting me here today to talk about the 2011 budget, and look forward to the opportunity to respond to questions. But I want to spend just a couple of minutes framing our budget, which I think advances the department's central goals: improving the health of all Americans, expanding access to high-quality health care, and providing children, families, and seniors with the critical health services that give them a chance to thrive. To do that, we've tried to make prudent investments that actually echo the goals that the members of this subcommittee have championed for years: attacking healthcare fraud with new tools and more resources, a new focus on preventive chronic disease and promoting wellness, emphasizing a reduction in medical errors and improving the overall quality of care, and strengthening our public health system so that we will be better prepared for new threats that come at us. At a time when so many American families are trying to balance their own household budgets, we think it's appropriate that we not let taxpayer dollars go to waste. So The budget reflects the difficult, time-consuming work we've done over the last year to try and eliminate waste and fraud and focus our resources so they can make the biggest impact on Americans' lives. Last month, you heard from our department's Deputy Secretary, Bill Core, about some of the expanded efforts to identify, prosecute, and prevent healthcare fraud as part of the new partnership with the Justice Department known as HEAT. And this budget, Mr. Chairman, builds on that progress. It adds new fraud-fighting funds to help us expand proven strategies like putting Medicare fraud strike forces in cities that we know are hubs for fraudulent activities, and invest in promising new approaches like the systems that will help us analyze claims for suspicious activity in real time. When the budget takes effect, it's going to be a lot harder for criminals to get rich stealing from seniors and from the healthcare system. And over time, we believe the anti-fraud efforts will pay for themselves many times over. The budget also takes aim at medical errors. We know that the quality of healthcare in America varies widely, and most tragically, in the case of tens of thousands of Americans who die every year from health-associated infections, many of which are preventable. Chairman Obey, you have been a national leader for eliminating these unnecessary deaths, and our budget is aimed at helping to do that by doubling the size of the CDC National Healthcare Safety Network to 5,000 hospitals. You also mentioned the need to be ready for immunizations, and I want to thank you for your support of the CDC Section 317 immunization program, which we've asked to receive additional funds to make sure that all Americans have access to vaccine that are the best protection against some of our most dangerous diseases. Investments like these will help make sure that Americans get the best possible care when they're sick. But we also have to do a much better job keeping Americans healthy in the first place. So this budget builds on the Recovery Act's significant investment in health information technology, which moves us closer to nationwide interoperability and helps providers make health IT part of their daily routine. We try to build on the historic investment in prevention and wellness that Congress made last year in the Recovery Act with new efforts that will reduce the harmful effect of chronic disease in our cities and create a new health prevention corps and aim at preventing unintended pregnancies. And because minorities and low-income Americans are likely to be sick and less likely to get the care they need, our FY 2011 budget makes critical investments in areas like community health centers and HIV/AIDS prevention and treatment so we can address the disparities that have plagued our health system and our country for far too long. HHS has spent our Recovery Act funds responsibly, balancing the need for getting these dollars into the economy with assuring the proper stewardship of taxpayer dollars. By January 2010, HHS Recovery Act recipients reported having created at least 30,000 new jobs and saving millions of jobs. The April report period has not yet concluded, but we fully expect those numbers to rise. By the end of September, we fully expect to obligate the remaining $6.8 billion in Recovery Act discretionary dollars available for FY 2010. So these are just a few ways that our department will work to build a healthier America. At the same time, we'll continue our work, which is already underway, to effectively implement many of the provisions in the historic health insurance reform legislation that Congress passed last month. The Affordable Care Act enshrines the principle that every American should have access to the health care they need. It also begins the transformation of our health care system with a wide range of new programs and incentives to promote the kind of coordinated, patient-centered, evidence-based care that has been shown to generate far better health outcomes. These changes, along with the investments in our FY 2011 budget, will mean that Americans getting access to care as part of the Affordable Care Act will be joining a health care system that's more consumer-friendly, provides more security, and more importantly, does a better job at keeping them healthy. Those are the goals, but we cannot accomplish any of them alone. We rely on partners across the federal government, in states, in communities across the country. and no one has a more important role than those of you in the United States Congress. So I want to thank you again for the opportunity to be here today, and I'd be happy to respond to the questions.
Thank you, Mr. Chairman. A while back, I found the comments made by our Speaker of the House, Ms. Pelosi, quite interesting. Specifically, she said on March 9th, before the legislative conference on the National Association of Counties, that, and I quote, "We have to pass the bill so that you can find out what's in it." My preference is that the American people know what was in the bill before it is passed, but I suppose that's just a philosophical difference. I was even more interested in a recent Rasmussen poll that shows that 56% of Americans believe that we should repeal Obamacare. In Kansas, it's more like it's over 70%, probably because 4 out of 5 jobs are small business jobs, and there's a great deal of concern about what it will do to small employers. To be honest, I'm not particularly surprised by that number, and I expect it'll grow since American people are only now beginning to find out what's been done in the bill. This bill is widely unpopular. What is the most difficult part for the administration to sell to the American people?
That's
Yeah.
the question.
Which part of this bill do you think will be the most difficult to convince the American people that it's going to be good for them?
Well, Congressman, I think there's been an extraordinary amount of misinformation about what the law is and what it isn't. And one of the jobs that we have, I think, moving forward, and I look forward to, frankly, is telling people what's in the bill. For instance, for small business owners, there's a lot of misinformation about mandates that currently are not part of the law, were never part of the law. So any employer who has less than 50 employees has not only no mandate, but may be eligible for tax breaks that begin this year at 35%, helping to secure employee coverage. And eventually, in 2014, we'll have access to a new market. You and I know in Kansas that small employers are often squeezed out of the marketplace, priced out of the marketplace, don't have the leverage, whether they're a farm family or a small business owner, that the large employers have. They don't have negotiating power, and they'll have opportunity to a state-based exchange.
I'm sorry, I have a limited time. Because of the cost, there was an article in the New York Times that talks about the effects of the new law, and that it will have on the new law will have on insurance premiums that are routinely paid by ordinary Kansans, as you mentioned. Specifically, the article focuses on mandates contained in the new law that have been in place in New York and Massachusetts and a few other states. The article concludes that people who buy their own insurance, and that includes the self-employed, people who work for small businesses and early retirees, those who do not yet qualify for Social Security, will have to pay on average an additional $2,100 for their health insurance. How does the administration justify forcing Americans who form the backbone of our economy, specifically those associated with small businesses, to pay an additional $2,100 for their insurance? Did we learn anything from Massachusetts, New York, and other states that have been doing some of these things that are contained in this new law, or is the New York Times wrong?
Well, I would suggest that the New York Times may be pricing a policy in Massachusetts, but is not pricing what will eventually be a state-based exchange in Kansas. The law is set up in a way that Kansas will have an opportunity, if they choose, to put together a state-based exchange, to have the policies and programs be state-based. It doesn't import the mandates from Massachusetts and impose them on Kansas. It really is the law of the state of Kansas. So I haven't read the article, but the state-based exchanges, I would suggest, will make it much more affordable for those in the individual market or the small group market to have affordable care, because they currently don't have the bargaining power and they are squeezed out or priced out of the market.
I'll submit that article for the record, Mr. Chairman, if it's okay with you. While I'm not a lawyer, I'm aware that I'm aware that the Supreme Court has declared unconstitutional many federal laws that contain individual mandates. However, the new health care law contains a provision that appears to mandate that every individual in the United States must have some form of health care insurance. Regardless of the lessons we've learned in Massachusetts and New York with respect to individual mandates, what makes this administration think that it can constitutionally mandate that every American must buy health insurance? And I ask specifically because there appears to be a fairly large segment of the American population that chooses, for one reason or another, not to buy health insurance, even though they can afford it. This is a basic issue of liberty for me, not unlike deciding to purchase a house or rather to rent. So what is it about the mandate that we think we can impose on the American people, and do you think it will survive a constitutional test?
Well, Congressman, I am also not a lawyer, but I have discussed the constitutional challenges with both our legal team and the legal team at the Justice Department, who feel that the Commerce Clause gives a strong constitutional basis for the personal responsibility section of this bill. As you know, when Governor Romney signed the Massachusetts law, he felt that a critical piece of expanding health coverage was personal responsibility, that those who could afford actually to purchase coverage would do so, and if they needed assistance, that the state in that instance, and in our instance the federal government, would provide that assistance, and there would be a waiver for those who couldn't afford it. It's the framework that we used to put together the Affordable Care Act, and I think at least the lawyers will debate this in the courtroom, but I'm convinced that it does stand on strong constitutional grounds.
Thank you, Mr. Chairman.
Ms. Lowy.
Thank you, Mr. Chairman, and welcome, Madam Secretary. Throughout the health care debate, one of my highest priorities was to enable the federal government to better track and prevent premium increases for consumers. One of the provisions in the new law involves medical loss ratio, requiring insurers to spend at least 80% of premiums on health care services. This will be a great benefit to those who cannot continue to pay skyrocketing premiums. The law includes a host of other cost control measures, including allowing exchanges to bar access to insurers with unreasonable premium increases. By the way, I found in my district, I had countless meetings with large employers, small employers, individuals, hospital doctors, and I cannot tell you how many people talked about their rates being doubled in the last 5 years. So we've got to do something about this in this bill. And if you could share with us, how does the budget request enable HHS to police insurers and protect consumers from abusive practices? And more generally, are there any changes to the budget request that are necessary now that health care reform has been signed into law? First, let's talk specifically about that medical loss ratio, and then whatever time is remaining, I'd appreciate it.
Well, the medical loss ratio, Congresswoman, as you suggest, is part of the Affordable Care Act. I'm a former insurance commissioner, and I'm familiar with looking at the kind of data that is currently going to be requested. So we have already reached out to the National Association of Insurance Commissioners to, as suggested by the law, have them help to frame the definitions that are used as part of the formula for the loss ratio. I've actually reached out also to my former colleagues, governors across the country, to remind them that in some states there is the full range of rate review authority, and in other states they're really missing big pieces of it, like California and others who found themselves in a situation where they do not have prior approval of rate increases, to remind them that that may be a good thing to address in their legislative session. So we are aggressively putting together the framework for a review of medical loss ratios and working in very close connection with the state insurance commissioners and the governors to do just that. I think that our budget, what we have done, Congresswoman, as part of the implementation of the Affordable Care Act, is to stand up a new office of consumer information and insurance oversight that is going to be charged with not only implementing the medical loss ratio standards, but a whole host of the market conduct standards for insurance companies, and working very closely with the state offices.
Before we get to the next question, from your experience, and you interact, I know, with other state commissioners before you took on these responsibilities, are there any states that are actually monitoring this issue effectively now? And I appreciate the fact that you said you've been meeting with the state commissioners of insurance. Are there any states that do it effectively?
I think there's some models out there that we look at very closely. Again, the state laws vary. So some states have what they call prior approval. Before a company can actually impose a rate increase, they have to submit actuarial data to the department, have it reviewed, look at administrative costs, overhead costs, CEO salaries, and what portion of the premiums they're actually paying out in health benefits. Others have what they call file and use, where the company actually notices you that you've got a rate increase and just files it with the department, and some don't even have that. So there's a wide range of oversight. We are very hopeful that we can, this isn't as you know, a federal takeover of anything. It really is a state-based insurance regulatory system that stays a state-based insurance regulatory system, but we're working very hard with the states to remind them that this responsibility is theirs. We have asked, I actually went to the health insurers and asked that companies submit to our office at a minimum their actuarial information of what their overhead costs are, what their benefit payouts are, so we can at least make it transparent to the American public. So far, we haven't had a terribly robust response, but I'm hoping that we will.
I look forward to your keeping us up to date on this issue, because from my perspective and many of my colleagues, we were moved to pass this legislation because, frankly, everybody, from small business to large business, was just getting rate increases. And my time is up, and I look forward to continuing to hear from you and getting this information. Thank you, Mr. Chairman.
Mr. Lewis.
Thank you, Mr. Chairman. Welcome, Madam Secretary. I don't envy you the challenge you have before you. All of us face the same thing, but you're in a very special hot seat. In general, I'd like to talk about medical errors a bit and a bit about Medicare, but before getting to that, as we've gone through this debate over the last year, it's become very apparent to any observer who's looked closely that the key players on the majority side, the President, the Speaker's closest advisor, Mr. Miller of Oakland, indeed Henry Waxman, have been supportive of a single payor system. Now, I know that's not the bill that we produced, but it lays the foundation for exchanges to become a lot more than state-based, but rather federal-dominated. And it concerns me an awful lot that we ignore that. Would you respond to you and your office's view of a single payor system at the federal level?
Certainly, Congressman, I'd be glad to. I think from the outset of this discussion, there were certainly those in the House and the Senate who favored a single payer system and felt that that was by far the preferable option. From the beginning, the President made it very clear that he did not, in spite of the fact that he had in years in the legislature and even when he came to the United States Senate, talked about that as an option that would be ideal. The more he looked at the situation with 180 million Americans having insurance coverage that was preferable to them and that they felt that what we needed to do was build on the current system. And that's really the structure that the bill took from the outset, in spite of, I think, the disappointment of some in the caucuses who would have preferred to really dismantle the third-party payer system. So that this really starts at the states. States put together exchanges either as a single state or in a multi-state area if that's what they choose. We provide technical assistance to the states to do that, and even though the exchanges are not the timetable for exchanges doesn't begin until 2014. We intend, starting next year, to begin very robust discussions so that we don't wait till the last minute and have states in a situation where they can't do this. We have already had lots of positive discussions, and states are very eager to do this. And I think it will very much be a state-based program, and particularly, Congressman, it is not to dismantle what's in place right now. It's really to replace the market for self-employed Americans, many of whom cannot find affordable coverage, don't have any leverage. A lot of small business owners who find themselves in the same situation.
If I could take you to medical
Yes.
errors.
Yes.
You suggest that within the department, you want to at least model some evaluation of medical errors to see how we can improve on that pattern within the health care delivery system. Might I suggest that one of the major federal medical health care delivery systems lies within our military? There is plenty of evidence that there is rampant across this system an error-based system of delivery. I would suggest that you might start there and help us with you to evaluate what's going on in that medical health care delivery system that supposedly is serving the most important servants we have in our society, the men and women who fought for this country. Huge problem there. I'd be interested in your reaction.
I'm sorry, I want to understand what you're saying, Congressman. We've begun certainly discussions with not only the VA but the Department of Defense on their systems. You're suggesting that there's a rampant medical errors within the healthcare system for...
There's evidence at the highest levels that system deliveries are, at best, produce an awful lot more errors than the norm, and we might start that examination right there.
Well, I think that's a good point, and I will follow up on that. Thank you.
One of the president's major promises was that if you like your health care, you can keep it. And yet, to pay for the new health care plan, the law, it appears, would cut in a major way Medicare Advantage by more than $130 billion. I have 50,000 plus seniors in my district who enjoy Medicare, and indeed they're concerned about what these proposed cuts might do to that service and existing delivery. But what can my seniors expect relative to implementing this program?
Well, I think that there is a provision, as you know, as part of the law that over a decade, a portion of the overpayment to the Medicare Advantage plans will gradually be phased out. There are about 400 plans, 400 companies right now offering about 1,100 plans throughout the country, about 11.5 million seniors taking advantage of those plans. We have just actually put out the 2011 Medicare Advantage updates, which will have the same rate payments for 2011 as they did for 2010. And noticed plans across the country. There will be a robust array of choices for Medicare recipients, as there are right now. I don't think there's any question that we are going to begin to pay more attention and collect more data, and the CMS on medical outcomes for looking at not only the fee-for-service side of Medicare, but also the Medicare Advantage side of Medicare to make sure that if enhanced payments are going out the door, it's really for a higher quality health outcome. And we know bundled care produces that, medical home models produces that, and there are a number of Medicare Advantage plans who are very eager to engage in that. But I think that the misinformation to seniors about the fact that Medicare Advantage is somehow not going to be a choice is just wrong. We anticipate that there will be no shortage of choices of Medicare Advantage plans throughout the country.
Thank you, Mr. Chairman. I must say, Mr. Chairman, that what you just mentioned is a major stumbling block, but if I were going to point to the greatest stumbling block, it's when the average family, let's say 25 to 45, suddenly finds a mandate with the IRS looking over their shoulder that they must start putting money into a pool for some future service delivery. Thank you.
I'd say the greatest stumbling block is when people with insurance have to pay $1,000 a year to subsidize people who don't have it, because we didn't have until now a program like this. Ms. Lee.
Thank you very much, Mr. Chairman. Good to see you, Madam Secretary. First of all, let me just thank you so much for your leadership in helping to move the historic health care reform bill forward, for your steady leadership and your voice and your experience. And also, for those of us who were adamant about a public option in terms of keeping costs down and holding the insurance companies accountable, we're counting on you to make sure that that happens, short of having a public option. And so thank you very much for understanding how important that is. Myself, Congressman Honda, Congresswoman Rayburn Allard, the Tri-Caucus was lockstep, very adamant on addressing racial and health disparities as part of the health reform bill. And I'd like for you to elaborate on how this budget actually supports the goal of diversity in the health professions through recruitment and training, how you increase diversity in NIH institutions and researchers, ensuring that racial and ethnic minorities benefit from any new innovative health research at NIH. Also, in terms of the direct support for our nation's minority medical colleges, the targeted support to help eliminate these disparities within communities where we see them the most. And so in this budget, just want to see how you are shaping this. I know that this year the Office of Minority Health, through the National Partnership, I think it's called for Action to End Health Disparities, has produced a draft report, National Plan of Action on Disparities. So I just want to get a sense of where you are on that. Secondly, and I'll ask all my questions right away, and then you can respond. Secondly, National AIDS Strategy, current budget allocation, who's going to lead the implementation of the National AIDS Strategy, and what part of the current budget allocation, I think it's $70 million, will go to, that's going to HRSA and CDC, will be dedicated to the National HIV/AIDS Strategy. Thirdly, let me ask you about nursing, because I had a long conversation with the dean of the Samuel Merritt Nursing School in Oakland, and she indicated that just in the Bay Area alone, 40% of all new nursing graduates since October 2008 have yet to find a job. Yet I thought there was a nurses shortage in our country. I spent a lot of time, as I say, I spent a lot of time in hospitals. My mother's 85 years old. My sister has multiple sclerosis. And I'm always, and these are very good nurses, but we're always being treated by traveling nurses, nurses who have retired and who come to the hospitals to work because I'm told that there's a shortage. And yet now the dean of the nursing school says nurses cannot find a job. So I'd like to kind of get some sense of what you think is going on out there and what I can do, what we can do to ensure that qualified nurses are being hired. And if I have any more time, I'll ask some more questions. But go on and respond to those. Thank you again, Madam Secretary, and good to see you.
Well, thank you, Congresswoman. I'll try to hit the high points on the issues you raised. First, health disparities is I think, glaring failure of the health delivery system over years. And while our department, I think, has done a fairly decent job documenting health disparities, there has not been a very good strategy to actually reduce or eliminate health disparities. So the National Action Plan that you refer to is really the first time since 1985 that there will be a secretarial level plan addressing health disparities. And it's one that I take very seriously. It is in draft form right now. We look forward to having a chance to preview it with you and to work on it. I don't think there's any question that passage of the Affordable Care Act is one of the most important steps we can make toward closing the gap. Over and over again, it's been identified that the lack of insurance, the lack of access to affordable health care is one of the underlying causes of health disparities, so a big step was made. Our budget actually will build on that effort in a number of ways. Not only will the Office of Minority Health focus with a strategic roadmap on this national plan, and we see it not only within our department, but an across government agency effort where health is impacted by neighborhoods, by food availability, by the air you breathe. There are a lot of things that actually add or subtract from people's health. So we see this as a government-wide effort. We do have additional resources in the 2011 budget that look at recruitment of health providers from minority communities to make sure that we have not only people serving in underserved areas, but actually minority providers, nurses, doctors, health technicians, mental health professionals. As you know, the Affordable Care Act also made an institute at the National Institutes of Health of the Health Disparities Initiative, and I think raises it to a level where it will have serious strategic focus and attention. So there are a whole host of assets coming together in a way that really hasn't been organized in our department. And again, we look forward. I know this has been not only a cause that you have taken very seriously, but your fellow Tri-Caucus members have been focused on for years, and I really look forward to working with you as we address these gaps and these underlying health causes. I would suggest also that the increased footprint for the community health centers, which actually started in the Recovery Act and are, again, targeted to the underserved areas, as well as the efforts in wellness and prevention grants, will also help to close this gap. I can't respond very well to the nursing shortage situation that you talked about, because that's the first time I've ever heard of nurses not being snapped up immediately to be hired. I hear the other side of the story over and over again, that people need more nurses in the pipeline, and that's exactly what we've been doing, is trying to fill that workforce pipeline with more scholarships being paid off, more increases to the health service corps, more people in underserved areas. So I need to follow up on that. And then finally, in the AIDS area, there is a national AIDS plan that is currently being formulated. It is not finalized at this point. As you know, President Obama has identified the fact that while we had a very robust international HIV/AIDS strategy, we had kind of lost the attention and focus at the national level. We have already launched under CDC an outreach program on testing, and particularly identified some of the most vulnerable and growing communities that we're beginning to interact with using social networking. But we look forward to the strategic plan, which will be led by Ambassador Gooseby and others who are focused on AIDS. There is a new AIDS Council, which will have a national and international focus, and we're going to be very intimately working with them.
Thank you, Mr. Chairman. Temporary high-risk pools in Montana, I understand you've been in contact with our auditor already about it, but I noticed in the appropriations, $5 billion was taken out of the general fund to pay for the high-risk pools around the country, but CMS is suggesting that the money will run out in 2011 and 12, and of course they don't have to be in place until 2014. Why the shortfall? Why the anticipated shortfall? And are there other areas that you see it's already coming in over budget?
Congressman, we don't know exactly how many people will be able to be enrolled in the high-risk pool. A lot of states offer high-risk pools right now. I think Montana is
Which is one of the reasons we wondered why we did this in the first place. If we already had the high-risk pool in place, why supplant it with something created by the federal government to do something that was already in place?
This is a totally voluntary program, first of all. Secondly, it won't be created by the federal government. If Montana chooses to set up what is a parallel pool, the money that is allocated in the Affordable Care Act is to subsidize rates,
the point
so
is,
they don't
if
rise above 100%. In Montana, they're
Correct.
well over 100% of the market right now, and it makes it very unaffordable for lots of folks.
But my question is, you asked for $5 billion, you got $5 billion, and CMS is already anticipating it will not last through 2011 or 12, and the high-risk pools are not to be in place by 2014. A shortage, a shortfall, an over-expenditure. How are you going to deal with it? Are you going to limit access?
Again, sir, this is not a federal program. It will be, if Montana chooses to participate, they will have an allocated set of resources which help subsidize care for Montanans who currently are uninsured and uninsurable.
Madam Secretary,
if they choose not to participate, that's a choice that the state will make.
Let's go back to the question. The question was, the legislation created high-risk pools, or the opportunity to create a high-risk pool.
That's correct.
By 2014.
No, sir. Right now, this is the bridge strategy to a new market.
Correct.
In 2014, not in 2014.
That is correct. But by 2014, a alternative structure needs to be in place.
The exchanges.
Correct. But if the exchanges are in place in 2014, but you're using Montana and the other states' temporary pool, and if you appropriated $5 billion and it's not going to make it to 2014, you're going to have to come back to this Appropriations Committee and ask for more money. You've already anticipated that's going to cost more than you told us it was going to in asking that the legislation be passed in the first place.
Sir, currently the federal government pays a fraction of a state's high-risk pool. It puts about $50 million into an overall plan. This is an attempt to provide a safety net coverage if the money actually is going to have a shortfall.
Madam Secretary, with all due respect, that doesn't answer the question of the shortfall. I understand the bridge. I understand that you're going to cooperate or participate or help the states, but you said it was going to cost $5 billion, your anticipated expenditure, and it's not.
Well, we don't know what it's going to cost, and I would
So you
suggest
disagree
no
with
one
CMS?
does, because we don't even know how many states want to participate in the program at this point. We've put out a letter to governors. I talked to my former colleagues yesterday. We will, by April 30th, have some idea. I mean, we really don't know at this point, sir.
Okay, the second line of question I'd like to go down the path. In the stimulus package, the law certainly says you can't lobby.
Right.
You know, the bastion of information from CNN. State of New York, obesity, educate leaders and decision makers about trans fat. This is a $3 million grant award. Santa Clara, California, advocating for an increased statewide tobacco tax. City of Chicago, tax increase at the city, county, and state levels. Iowa Department of Public Health, $3.3 million. Inform local policy makers about evidence and practice-based pricing. That sounds like lobbying.
Congressman, I read the same information from the same news source. I can assure you that we will follow to the letter of the law, the federal law, which prohibits federal funds and has, not just in the Recovery Act, but consistently prohibited lobbying with federal dollars. We will track that very carefully. We've already notified a whole host of folks that is the law of the land. That was part of the grant application. It will continue to be part of the monitoring. Federal funds will not be used for lobbying.
Okay, because those are all quotes from the grant application in the first place.
A lot of the applicants have a whole host of strategies that they employ and have employed historically, will continue to employ. We are funding programs that are not lobbying programs. They are actual prevention.
But your oversight
wellness.
missed it in the initial grant application.
Pardon me?
Your oversight missed it in the initial grant application. The grant application had those exact quotes in it.
They have been notified that there is an absolute prohibition for using any federal funding for lobbying, and we will follow up on that very carefully.
Thank you.
Thank
you, Mr. Chairman.
Welcome, Madam Secretary. Last year, the American Recovery and Reinvestment Act made $650 million in prevention and wellness funding available for chronic disease prevention and management. And this year, when Congress passed the Affordable Care Act, it included a $15 billion prevention and public health fund, of which $500 million is, I believe, available this year. And as I understand it, these new funds are not restricted to chronic diseases, but are meant to fund the entire spectrum of public health efforts. I've been told that your office is currently working on a system to distribute the funds this year. However, there seems to be significant concern in the infectious disease community that in an effort to obligate the $500 million by September 30th of this year, the department will fund only existing grant applications for the ERA chronic prevention grants, and that infectious disease programs will once again receive no funding. Can you please outline how you plan to allocate these funds and whether you will include new applications for prevention funds to target infectious diseases such as HIV/AIDS, viral hepatitis, sexually transmitted diseases, tuberculosis, many of which are at crisis levels in many communities, and what strategies is your department undertaking to address these infectious disease disparities in our minority communities?
Congresswoman, I would suggest that at this point, as you have identified, conversations are going on with members of the House and the Senate about the strategies for allocating these funds. So no decisions have been made at this point about either using traditional applications or not, but we absolutely want that kind of input and look forward to working with you on a plan. I think that the effort will be to actually build on, as you know, the investment in the ARA funds was really a first time ever investment in wellness and prevention, and strategically focused, at least in the community grant applications, on two underlying causes of chronic disease, which were tobacco cessation and obesity. This is likely to be a broader area. There are lots of ideas and good strategies about how to use this. We're looking carefully at the scientific data, at the evidence-based programs. I can guarantee you that will be one of the guiding lights, is what actually has been demonstrated to work. But I would say that discussion is very much underway, and we appreciate your your input.
So there's still
Yes.
open with regards to funding infectious disease.
Yes.
Okay. As you are aware, the United States spends more on maternity care than any other country in the world. However, we rank 41st in the world in maternal mortality and rank 30th in infant mortality. While we know there's an extensive body of research regarding best evidence-based practices in maternity care, our health care providers seem to be not to be following that research. For example, despite Healthy People 2010 goals of reducing cesarean births to 15%, the United States continues to have a 31.8% cesarean section rate. Given the risks that are associated with medically unnecessary cesareans and the extraordinary costs associated with cesarean births, is the administration doing anything to refine our care system to support the best and most cost-effective evidence-based care to reduce the rate of C-sections?
Congresswoman, I'm not sure I can speak with any specificity about what actions are currently being taken in dialogue with providers about the C-section rate beyond just publishing the data and highlighting the data. I can tell you that our Office of Women's Health is very focused on maternal and child health issues, and frankly what are pretty dismal health results, as you suggest, high expenditure and not terrifically good results. I again think that the Affordable Care Act makes a big step in the direction of getting affordable prenatal care to pregnant women. That will be a major step forward.
I'm sorry to interrupt because I see my time's up, but I did want to know whether or not, since the new law requires Medicare to cover care provided in all freestanding birth centers at a cost of $6,000 less, is there any consideration in the initiatives to increase the availability of licensed birthing centers across the country? Is that being looked at?
I can't answer that, but I will look into it.
Thank you.
Thanks.
Thank you, Mr. Chairman, Madam Secretary. I have two questions. One is about FMAP. Congressman Gow and all the Louisiana delegation as co-sponsors are supporting a piece of legislation to address Medicaid reimbursements or Medicaid costs. Governor Jindal is supporting the legislation, as well as Secretary Levine from Louisiana Department of Hospitals. They're in a legislative session today dealing with the shortfall there of $500 million. My question is, what is being done to prevent states like Louisiana, who were unfairly, when you look at the FMAP formula, because we got a lot of money into the state of Louisiana as recovering from the hurricanes. Louisiana was looked at as being a state that was financially better off than they really are. So what are we doing to prevent Louisiana or any other state like yours that received financial help from appearing to be wealthier than they really are, and therefore suffering because of the Medicaid.
Congressman, we have spent a good deal of time with not only your state health officials, your Medicaid director, the mayor-elect of New Orleans, and others, Senator Landrieu, on this situation. And frankly, one of the reasons I think that there is now a legislative discussion is because the law is pretty clear that we don't have administrative flexibility to change the calendar years for which the income level is calculated, and that's really the situation, is when the count began, what the income level is, and how it was calculated. But we are working very closely with them, well aware of the anomaly that income appeared to go very high because half the population was frankly gone and not counted, and probably inaccurately reflects what is the true medical count. And if we can have a legislative fix, we will try to move it very, very quickly. But we have our hands tied in terms of what administratively we can do for this situation. But I think it's really worth looking at, as you suggest. It's not only Louisiana, but what happens post-disaster in an area where federal funding may come in as an aid after the fact, but then the result is a calculation that isn't a very accurate picture of what the financial wherewithal is.
Thank you. And Chairman Obey a little earlier said something about a meeting that we had a few weeks ago about fraud. During that meeting, I asked the question. We heard all kind of reports about the numbers of physicians and other healthcare providers that were using sometimes information obtained from the inside to defraud the taxpayers. I asked the question about the number of individuals from the inside that might have been found doing something wrong. And again, I'm not pointing fingers, but I just find it almost impossible to believe that there are numbers of individuals on the outside committing fraud at the numbers that we are hearing about without getting some help from the inside. I mean, when we talk about organized crime, and that term was mentioned, organized means at least two. You know, you can't have organized crime with one. So I asked the question. I've not gotten an answer. I've had staff members to try to find out if, in fact, there are any individuals on the inside of any of the departments at all levels who have been found guilty of helping those on the outside. Can't get an answer. There's no answer, or either they won't give it to us.
Well, Congressman, I can tell you, I'm not aware, and I will make sure we get this data and get it right back to you. I'm not aware of, if you're talking about state and federal employees who have been charged and found guilty. I do know if inside means providers and not necessarily just doctors, but so-called equipment providers and home health providers. There are dozens and dozens of insiders in that instance who have been charged and prosecuted, which is really the only way that we would be able to document it if they've actually been found in some case. But I can get that information to you, and that's the kind of thing that I think the new fraud effort is attempting to crack down on. It's people who pretend to be providers, if you will, set up sham operations, bill, but they're not necessarily part of organized crime. They're just operating as insiders, but really conducting fraudulent activities. But we will circle back right away and get you that information.
Thank you, sir.
Thank you, Mr. Chair. Thank you, Mr. Chair. And to the gentleman's question, I know the department, unfortunately, I have to report, Minnesota found 2 internal problems with fraud. So you do internal audits, and I'm sad to report that there were people in Minnesota involved in it. I'm happy that they got caught. I would like first, though, however, to commend Chairman Obey for his ongoing instrumental leadership and fighting for the best value and quality in health care, and that just leads to a lot of hearings that you've had before and the hearing we're having today. And I'd like to congratulate you on the passage of the health reform bill. Your work and the work of the administration were key to ensuring that health care reform became a reality. I believe that the current Medicare payment system is deeply flawed, and too many hospitals and providers shoulder the burden of unfair Medicare reimbursements for high-quality, low-cost care that they deliver, my state being one of them. I look forward to working with you as you convene the National Summit on Geographic Validation, Cost, Access, and Value in Healthcare this year, and on this issue and the timing implications for some of the fact-finding that you're looking at, and for the implementation of change. I'm going to submit some of those questions for the record. So I'd like to spend my remaining time talking about hospital-acquired infections. We're here today to learn how to work more effectively with you to improve the quality of our healthcare system for all Americans. Hospital-acquired infections contributed almost 100,000 deaths, and a recent report under HHS concluded that hospital-acquired infections merited urgent action. We know that the hospital infections add $28 to $33 billion to our national health care costs. This is a serious public health care concern, because not are we only paying the cost, there are patients paying for these mistakes with their lives. HHS has set out a goal to reduce hospital-acquired infections by 10 to 20% in 2 years, and 50% within 10. But we're far from reaching that goal. We know that most of these infections are preventable through low-cost techniques. There's a New York Times article that even talks about how we've had remarkable progress in reducing infection rates, but how many of the hospitals and those have not yet worked to overcome these infection rates because they're in an entrenched medical culture which is not changing. My state has worked to lower infections, and I know others are doing that as well. And as you have examples at your department on how we can reduce infection rates. But the report also points out that infection rates have gone up 8%. So here's my questions. Is the 8% increase because of better reporting, whether it's voluntary or mandatory? Because you can't address a problem until you know and you face the fact that the problem exists. What are some of the obstacles to addressing this issue? Does the agency need this committee or the policy committee to work more closely with you to address this public health care concern moving forward?
First of all, Congresswoman, I think your targeted concern is one that is a huge issue, and it's not only a huge cost issue, it's a huge safety issue. And I know the chairman has been working with you and sort of focused like a laser beam on this. The notion that we have 100,000 deaths a year from what happens to people when they're in the hospital, not what brought them in the first place, is frankly totally unacceptable. And hundreds of thousands more in just high-cost, longer care strategies and lingering diseases. So it's a very serious issue. We know what works. It's been demonstrated and proven. It has never been taken to scale. It is not taken to scale. So I think a couple of things are happening simultaneously. First of all, the notion of increases, I would say, is a part of better reporting. It also is a snapshot of the past. We're hopeful that more current data gives some more encouraging signs. And this focus by the department, by this committee, through the Recovery Act, through the Affordable Care Act, and through our budgets, I think is relatively recent. Secondly, there's no question that it's a question of focus by hospitals. You have required, as part of the Affordable Care Act, that all hospitals now have to report, which is a big step forward, and that reporting will be much more transparent to consumers and others, which is, again, a big step forward. Third, we are putting real resources both to states for more frequent inspections and to hospital systems to encourage the adoption of the strategies that we know work. Fourth is the electronic medical records. I was in a hospital in Cincinnati 2 weeks ago in a children's hospital, which does some of the most complicated surgeries on infants and even prenatally that I've ever seen. They have embedded into their electronic record system the checklists that we know work to reduce hospital infections. They've gone 1,000 days without any safety concern. It's a great example of what meaningful use in a electronic record system can do, which is embed the kind of safety checklist, make sure it's done time in and time again. And if you can do it in that kind of environment, we can do it everywhere. So I think there's some resources coming together, but I can tell you it's something that we take very, very seriously, and I think is not only a huge cost, but we're killing people by our healthcare system.
Thank you, Mr. Chairman. Madam Secretary, thank you for being here today. As I talk to hospitals in my district, and it's a pretty rural district, a lot of small town, a lot of Medicare, Medicaid intensive facilities, most of them are expecting, and this is not through your actions or through the health care bill, so their Medicare reimbursement rates are being cut, they're going down. They look on the Medicaid new population that they'll be getting under the health care bill as largely a break-even deal for them. They're really not making money off that. And they're very worried about what's going to happen to the private provider part of reimbursement, because the point's been made here earlier, private insurance subsidizes the uninsured, but it also subsidizes Medicare and Medicaid to a large degree, because those programs don't break even on cost. So they're looking at their future, and they're wondering where the dollars will come from for them to be able to literally keep their doors open. And then the people in the larger cities wonder what happens if those smaller hospitals close and that population base is moved into their facilities. So I'd like you just to walk through, if you could, how you see hospital reimbursement rate developing over the course as you phase in the new health care bill.
Congressman, I think that's a great question. Whether it's in rural areas in your district or in a state like Kansas or in urban areas, I think every hospital administrator who I've talked to in the last 10 years has seen their uncompensated care rate rise. So there is currently a population with no payment stream at all, and then insufficient payment streams, and then private payer streams. So I think one of the features of the Affordable Care Act is actually to have a payment stream arguably under every patient who comes through the door, and it's one of the reasons that a lot of the hospital systems work carefully with us on the framework of health reform. I do think that there also is an effort where the kind of bundled care strategies, again, hospital providers are very eager to have a payment system which actually looks at ways that they can be more appropriately compensated for keeping people out of the hospital. Right now, the only way they actually get compensated is if somebody comes back into the hospital. And the sorts of embedded directional changes in the delivery system for health homes and bundled care and accountable care organizations actually have, I think, some huge advantages for hospital systems to have a more appropriate reimbursement system and actually keep people healthier in the long term. But I think there is a notion that we hopefully will have a care system that more appropriately, I'd say the third piece of the puzzle is a lot of hospitals right now, particularly through emergency rooms, are delivering care which could much more effectively be delivered in a primary care setting, in a community health center, in a variety of areas. They've begun to work on strategies to kind of triage that care so they don't have to have this robust sort of preventive care work, and that, I think, is also part of the new structure.
A lot of, again, my facilities are concerned with, again, on the private end of it is where they make the money, frankly, to reinvest in technology and facilities. They don't make that off Medicare. They don't make it off Medicaid. They don't expect to make it going so they're really worried, are we going to crowd out the private market here, and they won't have the money they need to give patients the best service that they possibly can give.
Well, and I think with the exchange opportunities, the private market, I would suggest, may be stronger. What's happening right now, and has happened over the last 5 years certainly, is more and more small employers have dropped their private coverage because they can't any longer pay the premium. A lot of individuals are lost insurance when they lost their jobs, but I think the restabilization of a marketplace, of a private marketplace with larger purchasing pools, but then stabilizing that coverage that people have, is actually going to be good news for a lot.
Well, I hope so, and I think that's a point worth making, though, because a lot of my friends who favor the public option, a lot of my friends forget where the money comes from that actually allows health care to be delivered, and it's very heavily from the private sector. You overpay, quite frankly, if you're on private insurance already. We know that's actually a problem that was alluded to earlier, but that also supports Medicare, Medicaid, and frankly, the new health care insurance bill as well. So I'd be very careful about killing the goose that's actually provided the eggs for everybody else.
Well, and as you may know, that of the 32 million or so estimated new enrollees in a health insurance system, the majority of those individuals will be in the private market, will not be in the public market.
Thank you, Mr. Chairman.
Thank you very much, and welcome, Madam Secretary. Just to pick up on your last comment, the additional 32 million that will be added to the population, would that tend to drive the costs down across the board in terms of insurance premiums if we have the other things in place like the antitrust provision and a public option?
Well, Congressman, I think what is anticipated to cost less is, first of all, the market right now is pretty fragmented. So if you are a individual buying your own coverage, or a small business owner, one health incident, one cancer survivor, one heart attack puts you in a very expensive category. Pooling that risk into an exchange, a much bigger purchasing pool, I think, helps balance the costs overall, and I think it's one of the reasons that costs will come down. And hopefully a number of the underlying features that actually lower the overall health care costs also are impactful in terms of the health insurance costs.
Yeah, it seems to me that that's something that we can work towards and anticipate. We do know, though, if we don't do anything, we have 47 million people without insurance. And the costs continue to rise. In the last 18 months, at least in California, the premiums have gone from 30% one year, 38% this past year in terms of premiums increase in the light of the debate we had already. So it's, I'm not sure the word is arrogant, but it sure is pretty bold to do that while we're having a debate on the high cost of insurance. I want to thank you for taking on this job. It's a massive job, and I think it's a very complicated, complex job that you have, but I'm looking forward to working with you on this. I would note that the state you do come from is a very active state, and they're very vigorous folks, and I was pleased to see that a congressperson did vote for the bill, and I think that in my own district, District 15, which is Silicon Valley, which has probably the highest per capita of postgraduate folks, probably the highest average income in this country. I had something like 70,000 folks who were uninsured. That's almost 10% of my population. Doesn't mean that they were unemployed, but they were uninsured. A fellow who ran against me for office when I first ran, a young man, a good friend of mine, said that during the current situation, he would not be able to go into business for himself because his child has a pre-existing condition. And he said, my past opponent and friend said, go for it. It's important for our country. What's important for our country also is that we know that we have a viral hepatitis issue in America and globally, and that we know that more Americans have chronic viral hepatitis. There's more of an incidence of that than HIV/AIDS, and the disease is 100 times more infectious than HIV. Well, I'm grateful for the President for requesting an increase for the division in your 2011 appropriation budget. I'm glad that Assistant Secretary Coe, with whom we had met, had begun two major interagency task force on this issue, and we're very appreciative of that activity. And I'm also aware that there's about $500 million for prevention and wellness funds that's made available through this bill. But there's nothing that says how it's going to be spent. Do you have any idea how your department will be looking at that and how it will be spent?
Congressman, I think that we are still seeking guidance from members in the House and the Senate about that 2010 appropriation for the prevention funds. We did invest both our 2010 and we have a spend plan for the 2011. I mean, the 09 and 10 prevention funds as part of the Recovery Act, and we see this as an opportunity to amplify and maybe look in some other directions. But those conversations are underway, and we'd appreciate your feedback.
We certainly will be willing to do that. I also know that, thank you, Mr. Chairman. I'll wait for my next round.
Thank you, Mr. Chairman. I want to personally thank you for all of your leadership with regard to the healthcare reform efforts and trying to push it through. I think history will judge us well, bringing a level of social justice to this country that we haven't seen. One of the issues that I've mentioned to you before when you were here that I've been dealing with and working with for the past few months and years is the issue of stress in our society. And I think as we talk about healthcare reform and the technology and everything else, that there's a growing body of evidence, not just in the area of healthcare, of mindfulness and contemplative practices and their benefits on reducing stress levels and allowing our body to heal itself. And so as we're moving 30 million more people into the system, there's inevitably going to be more costs, and I think we have dealt with that, and it will reduce costs, and I think we have dealt with that. But we need to, I think, pursue, and Mr. Honda just mentioned prevention, and I know there's going to be a panel to evaluate what preventative measures actually work. So if you can just talk about that. But I would also like to encourage you that on that panel should be somebody who has been in the field, working in the field of mindfulness-based stress reduction. I think it's the most cost-effective way for us to drive down healthcare costs. It's about individual responsibility. It's about teaching people how to manage their own health, right in line with everything else that we're talking about. So I want to encourage you to do that. And it's not just in the area of health. We have the Defense Department is now doing this for pre-deployment for soldiers who are going over, allowing them to and hopefully prevent a lot of the post-traumatic stress that goes on when these kids go into battle. So I want to encourage you to do that. And if you can talk for just a second about the panel that's going to be created to evaluate preventative, adequate preventative measures in the healthcare reform bill.
First, Congressman, I'm all for looking at any strategy we can find that is successfully reducing stress. I'm at the front of that line. Would be grateful for that evidence. I think that whether it's in this instance or the framework for the services with the exchanges or others, certainly we will put together a very broad-based group of experts and look at what the evidence says. And in this area, I think there are a number of cost-effective sort of patient-centered strategies that really do work. And so I look forward to getting the information from you and making sure that's part of the discussion.
I will get it to you. And I think the younger people are gravitating. I was at a conference this past week, and there was someone from Ms. McCollum's district at University of Minnesota. They're offering basically a stress reduction class for incoming freshmen, there's a 50-person wait list.
Wow.
I mean, so this is something that is throughout our society. So I think your leadership on this could be critical. Another question I have, and it's someone I think one of my colleagues mentioned the shortage of nurses, is the issue with primary care physicians. If you can touch upon that and how we're going to try to bridge our way through that.
Well, I think there's no question we need more healthcare providers all together, but we also need more of the providers to choose primary care, gerontology, family practice. So a couple of strategies simultaneously. One is using more of our loan and scholarship ability to attract people to those fields at the outset and pay off more of the debt for healthcare provider training in the areas that we see the biggest needs. As you know, the Affordable Care Act had a feature which actually, again, moved primary care providers for a couple of years with 100% federal funding from Medicaid rates to Medicare rates, which I think is, again, a big step forward to more adequately compensating the kind of work
I'm running short here. How about the bridge between, you know, those kids that they're going into school now maybe, and they're saying, well, yeah, it looks like primary care is going to be an opportunity for me, but at 2014 they'll be just getting their bachelor's degree as opposed to, or their BS degree, and moving on in the medical school.
Well, we're changing the Medicare pay rates also, so that there. I think payment of debt, payment of once you get your medical degree, are a pathway to a much more robust primary care system. That's what I hear from medical students all the time, that they are in a real financial box in terms of not being able to pay off their loans and being inadequately compensated once they become providers. So we're looking at both ends of that puzzle.
So you think they'll move over?
I do.
Immediately.
And actually, we've seen an increase already this year in primary care choices made by first-year residents. It's up about 20%.
Great. Thank you.
Thank you, Mr. Chairman. Welcome, Madam Secretary, and thank you for your efforts in helping us to pass what is historic legislation. And I know that your department is working overtime to make sure that we begin the implementation of this legislation, and that the people of this country can really experience the benefits as quickly as possible, and whether they are small business owners or seniors or young adults or parents or people who have a pre-existing condition. We've already seen a couple of instances where insurance companies seem to be changing their behavior in response to the bill. On the positive side, we've seen several companies who plan to move ahead of schedule to let adult children stay on their parents' plan until age 26. But there are instances in which we will need to watch insurance companies closely to make sure they're following the new rules that have been laid out. For example, some reports, including the Senate Commerce Committee, indications that insurers may be manipulating their medical loss ratios, reclassifying certain expenses to make it look like they're spending at a higher percentage of the premium dollar on medical care in order to meet the standards in the law. The Affordable Care Act included rate review provisions, including grant funding to assist states carrying out rate review to stop insurance from hiking those premiums to unacceptable levels. This law now bans a host of insurance company abuses, rescissions, denials of coverage for pre-existing conditions, gender rating, and health status rating. Let me just lay out the three pieces of this question, and I'll let you go. What resources and tools does HHS and the Department of Labor need for enforcement of health reform and holding insurance companies accountable? With regard to medical loss ratio, how are you going to work with the National Association of Insurance Commissioners to ensure that terms like clinical services, activities to improve quality are defined appropriately? They do not include routine activities that are more typically classified as administration expenses. And then today in the New York Times, there's an article that says Senate bill sets a plan to regulate premiums, and it is the federal government could regulate rates in states where state officials do not have sufficient authority and capability to do so. Let me ask you to comment on that. So if you could address those three pieces, I would appreciate it.
in terms of the resources and tools, Congresswoman, we are working very closely with both Labor and with Treasury that has a sort of piece of some of these puzzles on the initial regs, and that has gone pretty well. We have put together our office on consumer information and insurance oversight. It is going to be led by a former insurance commissioner who also has worked in many states around the country on regulatory oversight. We are working very, very closely with my former colleagues at the National Association of Insurance Commissioners, because this has got to be, frankly, a state-led, on-the-ground program. They are the ones who have this ability and information. And I think there's a very robust discussion. They're in the midst of identifying the terminology and definitions for the medical loss ratio. We're looking at some laws that are in place and work very well, and what the actuaries can actually take a look at. So it's something we're going to take very seriously. In terms of the rate review, the original Senate bill had a provision that Senator Feinstein was promulgating of a rate authority that would actually be the interim strategy between the time that the bill passed this year and the time that the new exchanges were in place. That rate authority was not part of the reconciliation measure, and I think would set up a framework where, absent state review authority, there would be a fallback review authority. And so I think that debate is likely to go on and may be an important piece of this puzzle, because right now, unless a state changes the laws and takes on this responsibility, there really is no fallback other than highlighting what rating is underway, but there is no rating authority right now with the Department of Health and Human Services, and we're encouraging states to do just that.
I'm really pleased to hear that. As you know, I do come from the state of Connecticut. We have, we probably the insurance capital of the country, but over and over again, as my other colleagues have experienced, the insurance companies, we've lived in their world for a very long time. It's now time for them to live in our world. And thank you, Mr. Chairman.
Thank you very much, Mr. Chairman, and let me join the chorus of gratitude for your leadership, Madam Secretary. But it does seem as though you are paddling upstream against the current. When you look at your budget, about 85% of it is really not under your control. It's reimbursement after people have gotten sick, and it's to the elderly, to Medicare, and most of Medicaid is still nursing home care for seniors. But something dramatic is happening in the health care of this current generation of young people that bodes ill for the future costs of care. Asthma rates have tripled in this past generation. 1 in every 6 American children now has a developmental disorder, attention deficit disorder, mental retardation, dyslexia. 1 in every 59 boys is diagnosed with autism today. After accidents, cancer is the leading cause of death among children. Primary brain cancer has gone up by about 50%. Childhood obesity has quadrupled in the last 10 years. And diabetes is out of control, about 25 million people now. And in fact, they now say 1 in 2 minority children will develop diabetes during their lifetime. That's unbelievable. Now, so it would seem that somehow we've got to get a handle on prevention. What's causing all this? Because it really is a dramatic change in the last generation. The First Lady's emphasis upon obesity, upon what people eat, is critically important. And I'd like to know how you're integrating that in terms of your program priorities. But it also may have something to do with the chemicals in the air we breathe or the water we drink or the food we eat. In fact, there was an analysis of umbilical cord blood in 2007-2008 that showed that the average infants had 232 industrial compounds present in umbilical cord blood. And so many people think there may be an endocrine disrupting effect on health care that is contributing to this massive increase in certain diseases. I ask you because you have responsibility for the National Institute of Environmental Health Sciences. I know they have some indication this may be what is behind these massive changes in childhood illnesses. I'm wondering if you have any plans to enable them to take a more robust, aggressive approach in terms of the environment's effect, as well as what you're doing in coordinating with the First Lady's Initiative on Obesity.
Thank you, Congressman. The statistics you recite are alarming and unfortunately very real, and ones that we have to take incredibly seriously. I think the shorthand is that we spend more, live sicker, and die younger than most developed countries, and there's something fundamentally wrong with that puzzle. So the First Lady's Initiative, as you know, is not only focused on kind of what you eat. That's a piece of the puzzle, but I think is a strategy that really looks across the areas and understands that kids are impacted, and the health of kids is impacted by what they eat in and outside their houses, what goes on in school, how much exercise they get, whether there's a safe place to play and walk, a whole host of strategies, and I think provides a template for the kind of thing that you're talking about. I don't think there's any question that first, reporting is better in this generation. Some of what you're talking about is probably highlighted by better monitoring, better reporting, but that doesn't nearly compensate for the incredible increases. Some of it is preventable in terms of what we're doing to ourselves, and some of it is likely to have environmental impact. My Assistant Secretary on Health, Dr. Koh, has re-engaged our department in a very robust fashion in work with the Environmental Protection Agency and others in looking at the health impact of environmental issues. Our HHS had kind of withdrawn from that space for a while, and we are very much back at the table. So whether it's looking at, carbon content or water-based diseases or air, which has a huge impact on asthma, the kind of air quality has a direct, there are huge health impacts on environmental issues. And I would suggest also that the Food and Drug Administration is taking very seriously a whole host of investigations in terms of, food content, chemical content, which may well impact people in terms of the fact, not what they're eating, but, the kind of cans, the bottling, a whole host of other areas. So this is all something that I think we're re-engaging in a very active way, and share your alarm at what the current health profile is for this country.
Thank you, Madam Secretary.
Madam Secretary, I have a number of questions which I'd like you to answer for the record. One on health professions workforce, another on pandemic flu, a third on LIHEAP, one on healthcare-associated infections, oral health, health information technology, and several others. But let me ask a couple questions about the bill that we just passed. Mr. Tiahrt and I are friends, but we often disagree. We're not disagreeable friends, but we're disagreeing friends very often. But I want to, in light of his characterization of the health care bill as a government takeover, let me ask a few questions. Is the VA a government agency?
Yes, sir.
Is Medicare a government program?
Yes, sir.
Is Medicaid a government program?
Yes.
I thought so too. Did we add to that list by making, well, let me put it this way. In this health care bill, is this like Canada or Britain, or is it more based on a private sector system?
The system is based on building out a private sector strategy with new health exchanges.
Will the doctors under the system work for the government?
Not unless they do right now. Some do for the VA, as you know, and for the Department of Defense, but no.
And what about the nurses? Are we adding millions of nurses to the federal payroll?
No, sir.
What are these things called, insurance companies? Are they public entities or are they private?
Private sector companies.
And are they usually a profit-making private entities?
From everything I can tell you, yes, sir.
I thought so too. What does this bill do for the fiscal solvency of the Medicare program?
Well, the estimate that was made when the reconciliation bill was proposed was that it added a minimum of 10 years to the life of the Medicare Trust Fund.
And what does it do to change the payment system from one based on frequency of procedures to one based on quality of medical outcomes?
Congressman, it sets a direction that for Medicare to become, I would say, a quality-based purchaser as opposed to the current strategy of fee-for-service, which is more about content than about quality.
Well, I agree with all of that. And let me just tell you a story, because we've had such controversy about and such points of disagreement about the details of this plan. Between 1930 and 1938, a fellow by the name of Jerry Boileau represented my congressional district. He was the last of the La Follette progressive Republicans. And when Fiorello LaGuardia became mayor of New York, he succeeded LaGuardia as the spokesman for the progressive Republicans in the House. And then he was beaten in 1938. My dad ran a supper club when I was much younger, and Jerry came home and became a local judge. And he came into our place one evening, and we started talking, and I finally asked him, Jerry, what beat you in 1938? He said, senior citizens. He said, I was strongly for Social Security, and in my district, the seniors were against it. I said, what on earth are you talking about? How can seniors possibly be against Social Security? Not the seniors I know today. Well, he said, in those days, it was different. He said, in those days, we had Social Security as one alternative, which is a contributory program. And then we had the Townsend Plan. Old Doc Townsend from California, who didn't want a contributory plan. He just wanted, I think it was $100 a month welfare payment to every senior. And he said, we all knew that that couldn't survive very long because the country doesn't like welfare. So he said, I strongly supported Social Security, and old Doc Townsend came into my district and helped organize Townsend clubs. And he said, they beat me. The point of the story is this. We look today, shortly after this bill is passed, and we see all of these little fights that we had, regional, ideological, philosophical, but I think 20 or 25 years from now, we're going to look back at this bill and say, what on earth was that fight all about? How on earth could we ever have functioned without this program? And I think all of these little fights that were so important to people as we were going through them, none of them going to be remembered. What will be remembered is that we finally put this country in the rank of civilized societies that do not require people with very little money to beg in order to get health care. That, to me, is basically the lesson of Jerry Boileau's story. And so I don't, I lost a whole lot more fights than I won on this bill. I favored public option. I have no objection to single payer. I frankly didn't care as long as we got two things. As long as we covered as many people as possible, and as long as we changed the rules of the game so that little people weren't squeezed by corporate giants called insurance companies. That's basically all I wanted. Everything else is candy. So I just want to thank you for the work that you did on this package, and to thank everybody who voted for it, and to thank those who opposed it and raised constructive questions along the way. Because to me, regardless of all of these little debates that we had, the obligation that all of us have now is to simply try to make this baby work, and to think through whether there have to be adjustments down the line. Make certain we've got plenty of oversight, and especially make certain that we've got a huge expansion of our efforts to go after waste, fraud, and abuse, because you've got lots of jerks in this society who will try to take advantage of this and rip off the taxpayer and rip off customers. Yeah. And if we believe in expanding these services, we just can't let that nonsense happen.
Well, I appreciate that, Mr. Chairman. I spent Easter weekend with my father, who turned 89 on the 22nd of March, and he served in the United States Congress on the Energy and Commerce Committee 45 years ago when Medicare was passed, and told me a number of stories about how ferocious that battle was, how ferociously a number of people opposed Medicare's passage, and how differently it looked then than it does now, where he's now a pleased beneficiary, and reminded me that over 45 years, there have been changes, there have been a number of improvements, but the basic tenet that once you turn 65 in this country that you have health security was a promise made then, and a promise that we intend to keep now. And it was interesting having his historic perspective on the beginning of this new chapter in American health security.
Thank you. I'm going to have to go over to the House for action on a bill that's going to be pending shortly. And so if I have to leave before the hearing is done, it's nothing you said. I just have to get over there.
I'm pleased to hear that.
And I'll ask Ms. DeLauro to take over if we're not finished by then. Okay. Meanwhile, what I'd like to do is just run a second round for about 3 minutes apiece and see if we can get everybody in for a second round. Mr. Tiart.
Thank you, Mr. Chairman. I want to remind you that the hearing isn't done, so maybe there will be something come up that will make you want to leave early. One of the things that concerns me greatly is about the cost of this, because, quite frankly, we've overspent this year by more than $800 billion this fiscal year. We know that there are at least 80 programs that are in the bill that require discretionary appropriations. And we have about $110 billion for these 80 programs. There are also 36 programs, at least, 3 dozen programs, that are open-ended. And I've asked the Congressional Budget Office to give us some estimate as to what they're going to cost. And they don't sound like very cheap programs. Of the 36, let me give you a couple of them. Community health insurance option, design and implementation of regional systems for emergency care, trauma care centers and service availability, oral health care prevention activities, programs relating to congenital heart disease, multi-state qualified health plans, community-based collaborative care networks, to name a few. So in addition to, it's my understanding that CBO has estimated that CMS, and the IRS will need an additional $20 billion in order to set up the systems just to implement Obamacare. So has your department developed a cost estimate for all these new programs that are not in the President's budget? And when will you be sending an addendum to the President's budget for next year to cover these costs? And where will the money come from?
Well, Congressman, you have our 2011 budget presentations, and there is not an intent to send an addendum to the budget.
How will you cover the cost of these programs that are not in the budget? it says in the law, such sums as required. Where are the such sums going to come from?
Well, my understanding is the way that process works, if there isn't authorization in the bill itself, this will be a discussion that you and your colleagues will have here in Congress.
So we're going to have to come up with the funding for these programs?
If the priorities of Congress are to move ahead on those programs, I assume they will be funded. But you have our 2011 budget submission and before you.
So we're the 302A allocation that we have and the 302B allocation for your department right now doesn't have a request from the President for such sums as required on these 36 programs.
That's correct.
So, Mr. Chairman, where are we going to get the money for these programs that we don't have any budget for and we won't have any allocation for? I guess he's involved in another conversation. My concern is that we don't have the funding for this and we have no idea how much it's going to cost. And again, we don't know where the money's coming from. China's not loaning us money on long-term Treasury bills now. The Fed has loaned money to the United States. They already owe us, or we owe them, $5.5 trillion as taxpayers. Where is the money going to come from?
Well, Congressman, again, I think that the programs are likely not to exist unless they're funded by Congress. That is not currently part of the authorized bill. I think the very good news for the American public is, unlike the last major health initiative move forward, the prescription drug benefit, this bill is paid for. It's paid for over time, and in fact, the Congressional Budget Office has estimated a $100 billion decrease in the deficit in the first 10 years and closer to $1 trillion decrease over the next 10 years. So this is fully paid for over the life of the program.
That you can't count Medicare dollars twice. We're taking money out of Medicare and adding them to the program that you're going to administer. Where's the money for the $500 billion taken out of Medicare going to come from? I mean, there is a lot of programs, Mr. Chairman, that don't have funding. They're not in the President's budget. We won't get the allocation for them. Well, I'm just wondering how we're going to fund them.
Well, let the chair say, first of all, the gentleman's time has expired. But let me simply answer the gentleman's question by saying there's a big difference between programs that are authorized and programs that are mandatory. And these are not mandatory programs to my understanding.
Well, are we not going to fund the community health insurance option? Are we not going to fund the oral health care prevention activities? I mean, there's no money allocated for
I don't have, I mean, given the fact that we have a good $17 billion hole in the budget on Pell Grants, I have no idea what we're going to be funding on anything.
Thank you, Mr.
And I
Chairman.
don't think anybody else does either. Who's next? Ms. Roybal Allard.
Secretary Sebelius, Congresswoman DeLaurel and I have been working together for over 10 years to reduce the dangerous incidents of underage drinking in this country. And we were very pleased that your administration recommended an increase to the Stop Act grants this year to enable more communities to address the critical problem. We have heard, however, that the HHS is looking to further expand its efforts in underage drinking prevention. And the questions that I have are, first of all, CDC and NIAAA are recognized leaders in developing evidence-based strategies on underage drinking. So what are you doing to ensure that the rest of HHS uses their guidance and their guidelines in implementing programs directed at preventing and reducing underage drinking? How will you ensure that the state public health agencies, with their own rich experience in tobacco control and other public health issues, are fully engaged in collaboration with state substance abuse agencies? And what will be the roles and resources available to the various HHS agencies to ensure that all of this happens?
Congresswoman, as you say, we do have a recommended budget increase for the STOP Act, and I think that's a step of directing more resources. We also have a talented new leader in the agency as my Assistant Secretary of Substance Abuse and Mental Health Services, Pam Hyde, who not only has run state systems but has worked in the private sector and run medical systems and is very tuned into this issue and is very much at the table looking at collaborative strategies. So we have the Agency for Children and Families at the table. We have our scientific-based evidence from CDC and the strategies that work on the ground. And we're working in collaboration with state and local partners to make sure what we know is effective actually is drilled down. So this is an effort. One of the things that the President made clear to all of his cabinet officers is that he wants us to leverage our assets not only across departments but within our own agencies. So we have a number of cross-agency collaborations, and this is one of them.
That's great to hear. Also, as you know, in fact, you mentioned earlier in an earlier statement the 317 vaccination program. And this program historically has been used for vaccinating children. However, each year hundreds of thousands of American adults are hospitalized and tens of thousands die from diseases that could have been prevented through vaccination. And it is estimated that the cost of the health burden to society from vaccination preventable diseases is approximately $10 billion annually. How will HHS use existing funding streams to address the issue of increasing adolescent and adult vaccinations? And has the department considered developing an adult immunization strategy, in particular what could be done, for example, to increase vaccination rates among healthcare workers?
Could we have a fairly short response, please?
We are working on this. I just was at the 44th annual vaccination week-long conference. We learned a lot of lessons from H1N1 that we intend to apply across the board, and one of them is how to deal more effectively with not only minority communities but with healthcare workers.
Okay, hopefully we can follow up on this. Thank you. Thank you, Mr. Chairman.
Cole.
Thank you, Mr. Chairman. I was listening to that wonderful story about Jerry Boyle, and I must say the moral I drew was that progressive Republicans always get beat by liberal Democrats that say they love them. So it's kind of a warning story there for me. On a more serious note, I share Mr. T.
But he got beat by another Republican.
I share Mr. T. Hart's concern about some of the financial basis of the bill. The one he particularly highlighted about the transfer of Medicare funds out for really a new entitlement program at a point when we've got a baby boom generation hitting Medicare age. I don't think it's going to hold. But let me ask you about another part of it that concerns me greatly, Madam Secretary. Right now, we assume that there's, and I think you said the majority of people moving into the system would be insured by private insurance. I'm not 100% sure that's accurate because numbers I saw suggested about half are going to be actually Medicaid patients. So at best, it's pretty close as to whether they're going to be purchasing insurance. And as I understand the bill, frankly, those younger people are going to have an option, while it's, quote, mandatory, they can pay a penalty as opposed to just buy insurance. The penalty that I've seen is cheaper than the insurance, and I would suggest a lot of them are going to do what most people in their 20s and early 30s do, and that's take the cheaper road out. Whether that's wise or not is debatable, but I think that's true. So how confident are you that the new people showing up to be insured, given the fact many of them are Medicaid, and given the fact that many of them have a way out and when they're young and healthy, are actually going to provide the revenue stream that the bill envisions?
Well, Congressman, the experience in Massachusetts, which is one that we look to, and there are other states who have, Wisconsin, again, has a pretty near universal insurance avenue, but in Massachusetts, a fairly similar structure, an individual mandate, with a relatively low penalty for failing to buy insurance, plus a low-income waiver or a hardship waiver, I'm sorry, has produced 97, 98% insurance coverage. The experience that they found is that people really wanted insurance. They just felt that there were too many financial barriers or health barriers, frankly, to get into the marketplace. So at least in the instance that fairly similar structure has been tried, there actually was a very robust take up, in spite of some skeptics who thought that people would opt out if they were younger and healthier.
Let me ask you, my time's about to run out, and it's a totally unrelated question, but I would one of the provisions of the bill that really concerned me, the treatment of physician-owned hospitals, and I realize there's a philosophical divergence in Congress over that particular issue. As in my state, they're some of the highest performing hospitals that we have by every rating. They provide excellent care, and we've been very pleased with them. What is the general attitude of the administration toward physician-owned hospitals looking forward?
I can honestly tell you I haven't ever been involved in a sort of philosophical discussion. There isn't any directional discussion. I think it's more come from Congress, frankly, and the alarm in certain areas of the country of the proliferation to what some have seen as the disadvantage of community hospitals trying to run emergency rooms and contributing to graduate medical education, and then being cherry-picked by provider-based hospitals. But I don't think the department itself has a directional strategy. It really is looking at high-quality, cost-effective healthcare delivery, and as you say, some are in physician-owned hospitals, and others are sometimes in community hospitals. But that's really our goal.
I'd just say in closing on that, just so you know, in our state, most of the physician-owned hospitals operate emergency rooms. They take Medicare patients, so they really stack up pretty favorably. And I would just commend you to consider that as one of the models going forward. I'm glad to hear that there's not an administration position per se.
Mr. Honda.
Thank you, Mr. Chairman. The health reform issues are also going to be including our concerns of children's health issues. And children probably comprise 50% of our Medicaid rolls. Will there be any thought about establishing a children's health task force? And leading up to that, my county of Santa Clara County recently has had the third highest rate of TB in California, and it's really grown from almost an elimination of TB in our county to being third in the state of California. Given that rise, and given the work that you're going to be required to do as far as traveling and everything else like that, I was just concerned that you had sufficient resources to be able to do the kind of travel and create the kind of presence that's going to be expected when you're going around the country to make the negotiations and be an advocate for this program. Those two questions, I'd like a quick response.
Congressman, I think in terms of the travel and presence responsibility, cloning would come in very handy in this instance, because I do think there's a lot of confusion and concern, and also a lot of eagerness about people wanting to know about the bill, how it's going to work, how it's going to be implemented. And I can assure you I'm going to do my best, and as are lots of members of our department, to be out and about everywhere. The Children's Health Insurance Program, which you all extended in 2009 prior to the passage of the Affordable Care Act, I think is a great focus on making sure that children have appropriate intensive care, particularly at the youngest stages. And we are undergoing a very aggressive outreach effort in conjunction with faith-based and neighborhood groups, with healthcare providers, with state and local partners to identify and enroll the approximately 5 million children who are eligible but currently not enrolled. It continues to be a challenge. The good news is even last year in very difficult budget times, states and local governments signed up an additional 2.5 million American children. We'd like to see that continue to rise, and I think that's, as you know, the S-CHIP program continues during the life of the Affordable Care Act, and I think that's going to focus that kind of attention and, services on the children's population, and one that we take very seriously.
Thank you, Mr. Chairman. Madam Secretary, know Ohio well. I represent a district in Youngstown and Akron, and in the city of Youngstown, we have two healthcare systems. One of them is Forum Health, which employs approximately 4,000 people in the region, and it is now trying to emerge from bankruptcy. Youngstown has about a 15 or 16% unemployment rate. The city of Warren has one very similar, and adding 30 million new people to the system, and many in Ohio and in western PA. I don't think now's a good time to see a hospital close down. And I was wondering if there's anything in your sights or from the administration that could help address this issue.
Well, my understanding is we solved one of the problems in terms of a payment stream that will continue during the discussion, which I think is important. And again, I think that the framework of having a payment system under the individuals who will seek hospital care in the future is a big step forward, and hospitals have really struggled. I also think that there were huge improvements made in the bill over the course of the discussion, dealing with disproportionate share allocation, where originally there was a thought that it could disappear entirely, and I think that was recalculated appropriately based on the fact that there are huge disparities in terms of the patient load that's likely to hit various hospitals. But I think you're absolutely right that we need a robust healthcare delivery system, and it's something that we're going to be working with local communities, looking at ways that we can provide resources in this kind of bridge strategy to make sure they continue to provide services.
Well, in the meantime, until 2014, when everyone comes in, I mean, hospitals like this could potentially close down. I know, and I think it's in Department of Agriculture, there are some loan guarantees, and maybe we can come up with some ways to help these hospitals refinance, because, you know, between now and then, a lot could happen, and the other hospital in town can't handle the influx that they could potentially receive.
Well, the community development block grant money, I think, which is in ag, and some other funding streams, I think we've got to be more creative about bringing other agencies in. The HHS really doesn't have either operational money or construction money with regard to hospitals, but I think having that dialogue with my cabinet colleagues is something that I'm going to pursue, because it's come up in a number of areas, and it's a very critical piece of the healthcare system. I think just like closing a school in a small town, you can't close a hospital or people won't stay in the community.
Right. So I look forward to working with you on that, because it's urban development, it's health, it's education, it's everything. So I appreciate that.
Thank you, Mr. Chairman. Madam Secretary, let me just ask a food safety a question of you. The volume of FDA-regulated imports has increased substantially over the past decade. The statistics say that FDA recorded 8.2 million imported food lines in 2007, fewer than 2.8 entry lines a decade earlier. You have just over 1% of these lines were physically examined and or tested. It's often reported that even with increased funding that the Congress has provided to the agency in these past 3 fiscal years, the FDA will still inspect less than 2% of import lines in 2011. This is mainly because the FDA relies on a very weak border inspection system. I also might add that there is indications that there potentially will be more inspectors, but we could have fewer inspections. Again, can you tell us, how do you think the FDA can improve in this area? There's the FDA food safety bill pending before the Congress in the Senate. How can that help to change this equation? And how do we deal with the improving the inspection ratios in the next 5 years?
Well, Congresswoman, first of all, thank you for your longtime leadership and expertise and interest in this area, and it is one that has changed dramatically over time. We no longer have an American-based food system, and I think that the regulatory framework is 20th century at best, and the system is global and increasingly global. Half our fruits and vegetables come from outside our borders. About 2/3 of the seafood comes from outside our borders, just to name a couple of products. No question that the new framework passed by the House and pending in the Senate is a huge step forward, and has a lot of the expertise of this committee's stamp on it, not this committee, but your expertise as part of moving that ahead. I do think that part of the strategy also is the FDA establishing a much more robust footprint in other parts of the world. So there are now 4 new offices in China. There are offices in Mexico. There are offices elsewhere, to not wait until products actually come across the borders, but look at the origins of those products. Secondly, I think it's critical that we have a much more robust and a different relationship with the private sector. The food industry often takes the hit at a time of a recall. They have enormous financial risks, but have been, I think, not as engaged and involved in self-reporting identification, quick recalls. The FDA needs some additional subpoena power, automated recall power, but also engagement of the industry at a much earlier stage, which again is part of the framework moving forward.
Mr. Chairman, just one final comment. I just want to say this to you, Madam Secretary. For years and years and years, the whole issue has been that trade in this area of food safety has trumped public health. Will be vigilant, I'm hopeful, but vigilant that that will continue not to occur, that trade will get in the way of what we can do with regard to the public health as it regards food safety. Thank you, Mr. Chairman.
I appreciate it. Thank you so much.